Okay, so I know we have a few folks that are here with us in person. So I'm going to call up the three of you together if that's okay. So first we'll have Kainlin See from On Point NYC, and then Magali Melendez from the Center for Court Innovation, as well as Dana Beal from AIDS Coalition to Unleash Power. So if the three of you could actually come up, that'd be great. Oh yeah, Dana, if you could come. Yes, right. That's good.
And Kaylin, you can start when you're ready. You could just make sure the red light is on the microphone.
And we have 2 minutes, right?
Yeah.
Okay.
Okay, can you hear me okay? Not really?
Oh no, a little louder.
Oh, I
Yeah,
think I
pull
did
it-
hit
pull
the button.
forward a little bit.
I did? Okay. All right. Hello, Chair Lee and committee members, and thank you so much for the opportunity to testify before you today. My name is Kainlin See, and I'm the Senior Director of Programs for On Point NYC, the operator of the 2 overdose prevention centers in the city. In 2017, the City Health Department issued a report suggesting that 4 overdose prevention pilot sites could possibly intervene in 130 overdoses in 1 year and save $7 million annually in downstream health costs related to emergency services, the healthcare system, and law enforcement. Today, our 2 sites, open only 7 months, have enrolled 1,400 people who use drugs, have been used over 25,000 times, 25,000 individual instances where a vulnerable New Yorker could have lost their life. Our highly skilled team has intervened in 350 overdoses with not one single death. But that's not news to you because, of course, you know that in 35 years, no one has ever lost their life from an overdose in an overdose prevention center anywhere in the world. We know this. We know there is a mountain of evidence to support these centers. Further, of those 350 overdose interventions, only 5 resulted in 911 calls. And I want to make clear that those are reasons not related to the overdose itself. Our team had resolved that overdose. They were related to underlying health conditions. I'll let you do the math. The cost savings are abundant, and the value of saving a human life can't be put into words. In On Point NYC's overdose prevention centers, we have a tangible example of what bold and brave action and political will can do, and what it can do quickly in the face of a crisis. I want to really condemn, we are indebted to our partners at City Hall, including you, and the City and State Health Department for their ardent support, their bravery, and their commitment to doing what had to be done. So thank you, and I don't think they're here anymore, but if they are, thank you.
Well, they're there.
On behalf of every soul who did not survive to use our sites, this is very emotional for me. Sorry. There is another opportunity to lead before us now. And I commend the mayor for his pledge to robustly support the existing syringe service providers in New York City in expanding their hours and services. This is desperately needed and a very smart investment that will yield results. But it's not enough. I'm asking you today to permit the opiate settlement funds to be used expressly for the operation of the overdose prevention centers and for their expansion across New York City to the other areas of high need. There are over 108,000 reasons to do this from just last year alone. Our 2 sites are sadly historic, long overdue, but finally open, and for this I am eternally grateful. The 2 overdose prevention sites in the United States are the only 2. Let's make history again for the right reasons and use these funds to expand this initiative immediately. We have continued to lose people, and I need you to understand that it's during hours when we are not open to save them. These are people that we take good care of during the day who have lost their lives in the overnight hours when we haven't been open. Lastly, we are asking for a real seat at the table as your experienced and committed partner to contribute and to advise on the development of a plan to resolve this crisis. I have been working in this field for almost 20 years. I want to help. Harm reduction for too long has been relegated to the sidelines. We very much look forward to seeing what we can do together. I'll close by inviting you all to visit our sites. If you haven't already, I know some of you have, but you need to see and feel how this intervention works in person. You need to meet the citizens who rely on them. You need to meet our staff. You will leave changed, I promise you that. Not one more death. We have the resources finally in front of us to make that a reality. Thank you very much, and I'll answer your questions.
Thank you so much for all the work that you do. It is, I know, tremendous, and it's very personal, I can tell. And so I just want to thank you so much for all of your work in helping out those that need help. And hopefully what we're doing with the funds and expanding the programs will really make a difference, like you're saying. So thank you so much.
Thank you.
Do you have any questions, anyone? Okay, and just want to acknowledge Councilmember Shahana Hanif, who is joining us as well.
Magali, you can begin when you're ready.
Yeah.
You could pass the microphone.
Just slide it through. Okay, thanks. Can you hear me? Yes. Good morning, Chair Lee and esteemed members of the committee. My name is Magali Melendez, and I am a program manager for the Bronx Hope program, which is part of Bronx Community Solutions. This is a project site in the Bronx, and we are part of a larger organization called Center for Court Innovation. The center has long-lasting partnership with the city, first-hand experience working in communities, and our research capacity allow us to provide unique perspective to assist the council. I'm sorry. Whew. Yeah, it's really hard. The council as is considered development and support of initiatives that effectively responds to the needs of New Yorkers suffering for the opioid use disorder. Distribution of the opioid settlement funding should support programs that offer meaningful and proportionate response geared toward rehabilitation that all impacted individuals with dignity and respect and prioritizing and public safety. To address the crisis, Bronx Hope, which is it's an acronym for Bronx Heroin Overdose Prevention and Education. It's a program that the center has developed to help individuals who struggle with substance use disorder at a precinct level. In the Bronx, which is, as we know, it has the highest numbers of overdose. It is this borough's first and only initiative providing 24 hours, 7 days a week, support and services to all 12 precincts in the Bronx. By providing the immediate and compelling engagement through a credible messenger who can engage at recently arrested individuals. The Bronx Hope program utilizes a peer engagement and harm reduction model to address the root of the causes of substance use and prevent overdoses. Bronx Hope peer specialists are dispatched to the precinct to engage with individuals immediately at the time of the arrest, and they are provided with a crisis bag. We have a small snack. We have fentanyl strips. We have Narcan kits. We train them how to use it. We give Metro cards and COVID tests, and we just provide support. We are grounded in the harm reduction model. These eligible participants can complete an assessment and engagement with a Bronx Community Solutions peer specialist and have their case declined to prosecute by the DA's office. Bronx Hope staff is staffed by case managers and peer specialists who have lived experience with addiction and deem as credible messengers. They distribute Narcan kits and their personal stories and experience to foster trust and meaningful connections to access to community-based health services and fit their individual needs. Case managers provide additional support, creating treatment plans with participants focused on comprehensive support, including substance use treatment, benefits of enrollment, mental health counseling, and many more. Bronx Hope demonstrates that eligible cases are more likely to engage in programming when a peer is present at the precinct. In 2021, Bronx Hope had a contact rate of 79% for dispatch cases. By giving individuals the option of accessing community services instead of appearing in court, Bronx Hope gives Bronx residents the opportunity for rehabilitation and connection to community over punishment and discrimination for their drug use. Bronx Hope can help an individual avoid a criminal record, which improves the access to employment opportunities, housing, and educational opportunities. Our success demonstrates the need to continue to expand community-based programming and of all touch points of the individual at risk of overdose. But more importantly, by providing the support and resources in collaborations with NYPD at the critical time of crisis, Bronx Hope ultimately saves the lives of these individuals. Peer specialists provide solutions that match local needs and resources. They foster trust and buy-in among our program participants and ensure that directly impacted have a voice in the decision-making of what they want with their lives. The scaling peer work-driven health and the housing intervention at various intercepts of the points, pre- and post-criminal justice involvement, can prevent overdose, promote harm reduction practices, and divert people away from arrests, further involvement in the system. Bronx Hope's success and impact has been a positive one, so much so that it became a model to other programs such as the rapid engagement at Midtown. Lastly, the center issued a set of recommendations for bringing peer work to a scale to combat the overdose crisis in New York City. And we understand that peer specialists provide solutions that match local needs and resources. I'm sorry. The scaling peer-driven health interventions at various intersection points will divert people not only from court, but just to live. What do we need to continue this work? We want to expand our work. We want to bring these peers more in communities. Peer specialists are the bridge to long-term care. They are the bridge between law enforcement and the community. We want to expand the access to networks to providers who are able to engage individuals in medical assistance treatment. We want to lift up medication treatment for sustaining recovery and preventing overdose. We want to continue to be funded for more peer specialists, to expand the availability and accessibility to treatment 24 hours a day, not just 9 to 5. Peer specialists, they educate. They educate people about the increase of overdose education and free community-based training and distribution. Peer specialists connect people to treatment and to community-based programming, pre-arraignment, before court. We don't want them in court. They are the connection. They are, I call it the secret sauce, right? I only oversee the program. They're the ones that really do this work. They're the ones, the front lines, the ones that walk every day. We work 24 hours a day to resemble the staffing at NYPD. You know, and a lot of our cases come 4 p.m. to 12 o'clock midnight when they really need the services. And it's really hard. I mean, we have resources, right? But it's so much limited. And it's really hard as a program manager to tell a peer specialist, well, there's nowhere you can take them at 1 o'clock in the morning, even though the participant is urging and screaming and pleading to our peer specialists that they need treatment. They need somewhere to go, and there's nowhere we can take them. And it's heartbreaking. We are asking to please fund us to continue this work. We do community outreach to hotspots. We're in the Bronx. We do Morisania. The 40th precinct is where we get the most of our dispatch calls, and we're there. We do footwork. We walk around and say, hey, if you ever get arrested, please tell us to call us. Tell the police officers that you want to call a Bronx Hope specialist. We are there to help you. We also, when we do our street outreach, we want to educate the community, right? Not only someone who uses, but people that don't use, that I live in Hunts Point. I work and live in the place that I'm serving, right? And I can see it. So I always walk with my Narcan kit, because I never know what can happen. And I want to make sure that our program educates and really takes away from that stigma of what harm reduction does, right? Like, what is that? And we use it every day. We use helmets to ride a bike. We use a seatbelt to drive a car. Those are harm reduction that we use on a daily basis. And we want to change that stigma, that narrative, that negative narrative that harm reduction has. We are asking not only that, yes, we already work 24 hours a day, but we want to have a mobile unit, right? Because it's really hard to engage an individual at a precinct level. I mean, we know why, right? If you're arrested and you're at the precinct, you want to leave. You really want to go. It could be because you're sick and you're thinking about your next high, and we want to avoid an overdose. And it's really hard to talk to someone there, so we want a mobile unit, a van, or something customized that they can come in and get the resources, and they can talk to us and really have a meaningful conversation rather at a bench inside a precinct. And we've been very creative in that, but it's not enough. It's just not enough. We want to continue doing our street outreach on the hot spots, right? Like 149 and 3rd Avenue, it's our hot spot. Aqueduct by Kingsbridge is our other hot spot. And we go out there and, we talk. We want to really have meaningful conversations and learn from them what is it that they need. We can be here all day and talking about what the community needs, but no one knows what they need but the community. And they tell us what they need, and we bring out what they need. The fentanyl strips, we buy that with our own programming money, which is not allocated for, but we know that's the need, and they asked us for it, and we bought it. I can sit here all day and just tell you about the stories and how amazing our peer staff is doing. They are very well-rounded, they have their lived experience, but they also are educated and professionals, and we want to continue to do that, because there's nothing that I can do better than what they can do. They just give something different. And I want to foster that, because that's what's needed in our community. And I'm screaming, even though I'm not literally screaming, but I'm screaming for your help, because we need the funding to continue this work. Thank you.
Thank you so much, Ms. Melendez. And I actually just had a couple follow-up questions. So have you guys been coordinating with some of the street outreach teams that are currently available? And if so, has that been working well? What do you think needs to be done better? Just out of curiosity, because I know there's like multiple street outreach teams, and so I just wanted to hear your thoughts on that.
Absolutely. Listen, there's no a cookie cutter for this, right? We know, and it's sad to know that each of us, the agencies, really, really compete for funding, right? And we know that. And it's just that's a sad way of like doing the work. However, what we do know, and what has been very successful for us, is collaborating, right? We have collaborated with NYRE, with Boom Health. We've done events together. Even, special days or not special days, we know that we have to do this work together. Why? Because we offer different things. Our goal is the same, but we offer different things. Like, even though me and her can do the outreach together, what I can offer in our programming is diverting you from court and saving your life, right? Because that's my goal. Her goal is the same, is to save her life. So yes, we've done that before, that we should continue doing that and growing. Absolutely. I think that's like part of the solution, is collaborating in a round table and being part of the conversation. Yes, so absolutely.
Okay, and then just out of curiosity, do you guys receive most of your funding from city contracts, or is it city, state, federal?
I don't want to answer that incorrectly.
Okay. Yeah, no,
How-
let's have an offline conversation. I'm just
Okay.
curious, yeah.
But we do get funding from MACHE, so.
Okay.
Yeah.
And then definitely look at the initiative funding and all that stuff that's out there. Okay. And then do you guys have any questions? Okay, go ahead.
There's something called the 12-step program. Do you have the 12-step program? Is the 12-step program still available?
You wanted to,
I think the question is for you.
for me, right? I know what the 12-step program is. So we're not a treatment facility program,
Right.
right? So our model is a harm reduction model, right?
Yes.
We educate every individual we encounter in the sense, these are all the treatment modalities that are available. Which one do you want, right? We
Right.
want to give that person the voice and the control of their own life. However, in that conversation, we do talk about what each modality is and what fits, what has worked and what hasn't, right? Because a lot of the individuals that we encounter have had a long journey with treatment. But we do talk about the 12-step.
Because the 12-step program, we've had that around a very long time. And what it is a group of people come together, like AA.
Right.
And they have proctors. So there's always someone, like you talk about your peer reinforcement, your peer enforcement. That's something that the 12-step program did offer. And they were ready at that person's side, whether it was 2 in the morning, 5 in the morning, 3 in the afternoon. They always had a go-to person.
Right.
And I find that the 12-step program was a huge support system. And to know that you're not alone, you meet a couple of days a week. Actually, the 12-step program was a program that was set up that ran any time of day and night. They would throw together a 12-step program in a church, in a VFW hall or whatever, a common space where 6, 8, 12 would get together, whatever the amount is, and they would at least lean on each other and then take them, or the person that's having the hardest time, to a treatment facility to get them through what they need to get through for that particular night, but most of all, to try to keep them focused, try to keep them straight. And that's something that I think would work. That mobile idea is awesome.
Thank you.
That is a great idea, because rather than have 1 or 2 destinations, you allow the destinations to go out into the street, which is great. Also, I totally understand about waiting on a bench in a precinct and not wondering what your fate is going to be. So there again in lies the enforcement that they need from a stable individual that maybe went down that same path and now is in a brighter light, but they are able to help. I find that those that were and suffered from are the best teachers, and to help those that are going through it right now.
Absolutely.
So I'm right there with you.
Thank you.
Thank you.
Yeah, and I think also, like, again, like I said before, that when we first started in 2019, we had this idea, right? But learning from the community, we know that what we needed to change and what we needed to expand. And being able to be able 24 hours a day, if a client wants to call us, a participant's like, hey, I'm struggling, the peers are there to pick up that call.
That's the best.
Even if it's just support, right? It's just someone to talk to, and that's okay. We also have warm handoffs, right? So if a client say today, like, I want to, you know what, I'll go tomorrow. We'll check in tomorrow morning and say, hey, we're here checking in, just want to say, you still here? We're going to go, we'll pick them up on the Uber, we take them, like, it's not just one box fits all for everybody.
right,
We
it's a
know
cookie
that each journey is different.
Correct.
And we want to honor that.
Thank you very much. Thank you.
I just wanted to acknowledge my colleague, Councilwoman Natasha Williams, who has also joined us. Thanks, Natasha. And I know that Councilmember Botcher also had a question as well.
You'd mentioned mobile vans. Those can be purchased with city council and borough president capital funds. And you may not know whether or not they applied this last year, but you should apply to the council for those funds because they're really great to purchase with capital money because they're only around $100,000. And unlike most capital projects, they can come very quickly. So I imagine if you asked Bronx Borough President Vanessa Gibson for a van, if you had asked the council members that you serve for a van, that should be able to get done. So I would suggest applying for that. The applications come out in January, are due in February, and then get approved with the budget in June.
Oh, thank you. I appreciate that. Absolutely.
Just plan for a couple years for that to come. I had to go through that as well. Okay, and sorry, so I don't know if anyone else had questions, but if not, then we will move on to Dana, am I saying that right? Dana Beal.
Is this registering? Good. First, I'd like to thank Eric. I originally approached Eric about some kind of modification or expansion of overdose prevention, and he sent me to you. So I finally got to you at this hearing. But actually, this is addressing, something you're talking about, which is the total deficit in treatment, right? There's nothing really that really works. You could put people on Suboxone. But imagine, instead of having to put somebody in a residential treatment for 6 months or a year, you could use that bed for a week and make a really huge change in that person's life. And then put them in in the community in effect, a 12-step program. ACT UP is sponsoring a bill in the New York State Legislature, A7928, the Therapeutic Psychedelic Research Act, to establish a research institute in the State Department of Health as the physical location in New York City for the study of actual treatments of addiction and serious mental illness with ibogaine and other compounds. Ibogaine is the first addiction interrupter for a broad spectrum of drugs. That is, it's opiates, alcohol, cigarettes, psychostimulants, cocaine, and methamphetamine, for which there is nothing. It's based on the novel mechanism of glia-derived neurotropic factor regeneration of dopamine neurons. Ibogaine treatment would immediately, under this act, become available in New York City. This is the treatment that Hunter Biden paid $6,000 for, and he said it was moderately successful. I don't know what happened to him after that, but wouldn't it be nice if other people could get it? At the moment, all we need is a Senate co-sponsor to get that passed. We have people in the assembly. Now, ibogaine was originally tagged for study in 1991 by the NIDA Medications Development Division, MDD, for crack and other psychostimulants. Although at the 150 clinics in 20 countries where it's currently in use, it is better known as an opiate detox. Because ibogaine abruptly abolishes both withdrawal and post-acute withdrawal syndrome. Perversely, this is viewed as an affront or a not-so-veiled assault upon completion of the rollout of Suboxone, which is one of the things this hearing is about, is further rollout of Suboxone, and Suboxone has its place. Meanwhile, methamphetamine is the principal drug problem in the the queer community, which I'm here representing. And Suboxone is completely useless for meth, as well as the growing population out in the USA who's dually addicted to opiates and meth. We have dual addiction now. So even if you give them Suboxone, they'll still be strung out on meth. The book, The Empire of Pain, introduced the reading public to Dr. Curtis Wright, who ran the FDA office tasked with working with NIDA MDD head Frank Vocci before Curtis hied off to a $500,000 a year job with Purdue, he sat down with Vachi and Clinton's new head of NIDA, Alan Leshner, and did three things. Released oxycodone, released Suboxone, canceled ibogaine. Ibogaine, which was being developed for crack, did not fit the paradigm of the single receptor medication like Wellbutrin, because among additional ketamine-like and other useful effects, it was a neurotrophogen. It uses nerve growth factors. In 1996, when they discontinued the NIDA ibogaine program, they didn't yet have the science to measure neurotropins. They kind of knew they existed, but they just hadn't figured it out. Dorit Ron didn't publish it until 2005. I'd say they canceled that program a little prematurely. And there's still no other medications that works for meth, even though Howard Lotsoff, who was from New York, his widow still lives in Staten Island, African-American lady, 86-year-old, proud, from the civil rights movement. Howard Lotsoff patented it for meth in 1986 or 87. Now, it would be better to secure a legal supply of various psychedelics via A7928, but the opening afforded by the current exemption from federal prosecution for overdose prevention does suggest a workaround in the current crisis. Nothing offers protection against ongoing exposure to fentanyl comparable to users walking away from opiates for the rest of their lives. And that's 41%, according to the Johns Hopkins Yale study at Crossroads. Almost 1 in 2 from one treatment or a short course of treatment. Overdose prevention is slated for expansion. That's pretty clear from this hearing. That is the other thing this hearing is about. Sorry, I got to figure out how to turn the phone off. We need not be limited to 2 tiny housing work sites with stalls to inject or smoke drugs and then leave, which is what they're talking about. I checked 2 tiny sites. Configuring some of that capacity that is coming with experienced paraclinicians to accommodate people who obtain ibogaine themselves on the internet. We'll get the process started while we wait for the legislative year to roll around. And the gay community will have a cure for meth. There is an existing recharge program. It's a meth program run by Housing Works for DOHMH, and it needs only to be able to offer a daily microdose. Detox from meth does not require the flood dose or a gram or more, which is required to quell opiate withdrawal. But where one must monitor for HERG, potassium, prolongation of cardiac QT. And recharge is already in the zone of tolerance, so we just need something in writing effectuating that. City Council already has all the power it needs over land use and buildings to earmark the expansion of overdose prevention for an iboga room. And, basically you're talking about something where they'd need about 36 hours, quiet, darkened, with, a nurse or something is trained to monitor somebody to make certain they don't have any complications. But then they can move along, go into aftercare, and get the benefit of complete. It's been compared to me, it's like you encounter your entire subconscious. This is not a hallucinogen. This is a sticky Prozac. This enables you to see in your mind's eye all this crap from your life that you're talking about, right? All the trauma. And you do it in a kind of a neutral state where it doesn't panic you.
Okay.
So we just want to be able to bring this to the gay community, but to do that, we have to do it for everybody else.
Okay.
So that's where
Thank you.
I'm at.
Thank you so much, Mr. Beal. And I know that Councilmember Eric Botcher actually had a question for you as well.
Hi. So to my colleagues, I invite you to look up Dana Beal's Wikipedia. He is it's a very long Wikipedia, and he has a very long and storied career in activism and was a powerful advocate for the legalization of marijuana going back decades and decades, way ahead of your time.
He's a bit of a legend.
A legend, yes, that's the word I was looking for. So you're essentially advocating for overdose prevention centers to offer additional types of treatment, including these cutting-edge psychedelic.
Is there any real reason it should be limited to coke, dope, and speed?
Right, so that was...
If they're all illegal drugs.
Right, so
right?
I just want to make sure we're all clear on what the proposal is. We have here the nonprofit, the folks who administer those overdose prevention centers. So I'd love to ask, you what you think of this idea now that we're all here together.
I agree wholeheartedly, and I have good news for you that On Point NYC is investigating implementing exactly what you're talking about through our harm reduction mental health unit. So we already have clinicians on our team who are experienced in the administration of iboga, ayahuasca, and ketamine, and we're partnering closely with them to integrate those services. Because they are evidence-based. They're still, in the US anyway, still considered to be a little bit on the margin, but they've been widely studied. They're very effective, and certainly at interrupting addiction in the way that Mr. Beal is saying. So full support.
Before the New York Post article trashing Nairi, you remember that article? I had dinner with those guys. There's a guy who worked there. I don't think he works there now. His name is... Dimitri Mugianis. He's famous. He had a movie made about him, Dangerous in Love by Michelle Negroponte. And he has done more than 500 ibogaine treatments.
That's who we're working
before
with.
He was victimized by a sting by the DEA in Seattle. And when he appeared before the federal judge said, if I could give you no time, if it was in my power, I will let you go, but I have to do something, so I'm going to put you on home confinement on a bracelet for 45 days. So that's the reaction in the system, is people know we need something more.
So it seems like there's actually a natural synergy in conversation happening right now. So I definitely think it'd be good for us to have a follow-up meeting after this, and I have my staff also in the back. So I would love to actually get your contacts before you leave. But I just wanted to be mindful because we have folks who've been patiently waiting on Zoom as well to testify. So I just want to be mindful that they're waiting as well. So I just wanted to thank you all for being here and for your testimony.
Who do I give these other 20 copies to?
Oh, right here.
There you go.
Thank you.
Thank you.
Thank you so much.
Thank you. And we'll next turn to our Zoom panelist, who is Dr. Noah Krawczyk, and apologies if I'm pronouncing that incorrectly. And we also have a registration from Karen Remy of Greenwich House, and I just want to see if they might be in the room. Okay. So we'll turn to Dr. Noah, who I'll unmute now. And you can begin when you're ready.
And that was a good pronunciation of my name, so I appreciate that. Good morning, Chair Lee and members of the New York City Council Committee on Mental Health, Disabilities, and Addictions. My name is Noah Kravchik, and I'm an assistant professor at the Center for Opioid Epidemiology and Policy of the NYU Grossman School of Medicine, and I've dedicated my career to studying evidence-based practices to address addiction and overdose. On behalf of my center at NYU, we are very grateful to the committee for its leadership in holding this hearing and really appreciate the opportunity to testify today. As you all know, in New York City, no community has been spared from the overdose crisis, but poor neighborhoods and communities of color carry a disproportionate toll of overdose deaths. The opioid settlement funds provide a critical opportunity to invest resources to prevent overdose, but doing so will require a pragmatic, evidence-based, and equity-focused approach. I will therefore summarize very quickly some immediate, medium, and long-term investments that could be prioritized in the distribution of funds. First, immediate investment should focus on expanding harm reduction services and supplies. Harm reduction organizations, as you've heard today, require additional resources to effectively reach individuals at high overdose risk and provide supplies such as fentanyl test strips. Efforts should also be made to make naloxone even more ubiquitous across New York City and really prioritize neighborhoods at highest risk. And as we've heard today, the 2 existing overdose prevention centers in New York City have already amazingly saved over 300 lives, but additional resources are crucial to scale up services to operate both 24/7 and across multiple boroughs and neighborhoods. In the medium term, investments should also focus on increasing access to low barrier treatment. Medications for opioid use disorder, including buprenorphine and methadone, are highly effective treatments that cut overdose by half. But unfortunately, they remain largely out of reach for the most vulnerable groups. The city should therefore invest in low barrier treatment models such as walk-in mobile units and those that are co-located with syringe service programs. I'd also like to address an issue that was raised during the hearing so far about inpatient treatment and say that when it comes to opioid use disorder, the evidence actually shows that residential inpatient treatment is actually not as effective as outpatient community programs that offer medications. So I really want to just be clear about this point, and I'm very happy to respond to more questions about this. The city should also expand resources to help link high-risk individuals from acute care settings, including both emergency departments as well as inpatient settings, to community-based treatment and other services. Finally, in the long term, investments should really focus on preventing future epidemics by promoting social services and prevention programs that are rooted in evidence and public health. This includes investing in programs that reduce poverty and homelessness and that divert individuals away from the criminal justice system, as we've heard from the HOPE program today. In summary, an approach to using the settlement funds that is centered in evidence and equity can help us overcome the New York City overdose epidemic, reduce disparities, and strengthen the health of our communities. And on behalf of our research center at NYU, we really would be thrilled to offer our research expertise on this topic to the committee in your ongoing considerations of this issue. So thank you so much, and happy to take any questions if there are some.
Thank you so much for testifying today and for being with us, especially over Zoom, and for waiting patiently.
Of course, thank you.
Okay, so I think with that, we're actually done. So I'm just going to gavel us out and thank you all so much for joining us today.